NCDs cause 30% of the deaths in this country, and 50% of hospital problems are due to NCDs, and that NCDs are the fastest growing cause of death in Africa, and that we contribute the biggest increase in NCDs currently in the world in Africa, about 27% in 10 years. Low and middle income countries actually contribute the largest amount of morbidity or disability from NCDs and deaths in the world. And therefore, it is the poor countries and the poor people actually who suffer most. NCDs beget poverty, and poverty also entrenches NCDs.
I was diagnosed with type 1 diabetes when I was 19 years old.
For 8 years, I suffered because I was not even accepting that I'm diabetic.
Hiyo time nilikuwa nimeificha kwa sababu hakuna mtu nilikuwa nimeambia, because sikuwa najua the symptoms za diabetes, so nilihave kwanza kuificha.
I didn't eat it and statement. You don't even believe that you have diabetes. You are so young, like I was 23 years old. You can't believe you have diabetes and you have a long life ahead of you.
Ile kitu nimeona ikiwa ngumu ni kwanza ile wakati sikuanga nimejitikia, sikuanga yani najipenda, naona haina haja niishingi. Nionangeani mabesti zangu tuko HMate, wao hawana diabetes na mimi niko nayo. Sasa nilikuanga yani najichukia.
I had to adjust to the life of being a diabetic. That is medication, that is checking my diet, that is exercise, and also stress management.
In the year 2010, this was around March, actually towards the end of March and the beginning of April. This is when I had a stroke. Very little did I realize that this was a stroke, because once there is an onset of stroke in you, you will find that you lose all what you are.
I was a teacher first of all, and I was teaching in one of these best schools in Nairobi. During that time, I used to live a very good life with my wife and children. But since I got this disease, everything changed.
Sikuwahi jua tangu nikiwa mtoto, nilipata nikiwa 4.5 years hiyo stroke. Sikuwahi jua ati nilikuwa na stroke, because nilisomea normal school, kila kitu kilikuwa normal. My parents walikuwa wamekubali Rose ako normal, so sikuwahi ona ni issue kubwa vile. But challenge ilianza vile niliingia high school.
I was sidelined. I was called various names, but my encourager, my father, I've accepted myself and tried to cope with others.
Kando na hii ugonjwa yake, kuna ingine ila anaangukanga. Akianguka achifahamu, ataweza anguka kwa barabara na achifahamu ni wapi yako wapi.
I wake up, I find myself this way. There before, I was well.
Nilikuja kujua niko na sickle cell at the age of 5. Then life ilikuwa tu sawa. I was a big mama, alikuwa ananiambia nilikuwa mnono sana back then, but ikafika point nilienda ushago kurudi ndo nikakuanga mgonjwa for almost 2 years. Hawakujua what's wrong, but nilikuanga napelekwa hosi na narudi home.
I've had
4 children and 3 had sickle cell. I've lost 2. I have one who still has sickle cell. The other one is a trait. A trait is a carrier like myself, but they don't exhibit symptoms.
Ya kwanza before nigundue juu alikuwa ananisumbua tu, nilikuwa nimesema amerogwa na si urogi. Kurudi kujua ni hiyo sickle cell, tukaanza kubishana na mwenzangu wa ndoa. Tunasema hii imetoka kwenyu, hii ugonjwa imetoka kwenyu. Sasa tunafurutana.
Nilikuwa nikigonjeka sana na hii ugonjwa na sikuwa ijua ni hii ugonjwa ya sickle cell ndio inaniumiza. Nakumbuka nikiwa na wazazi wangu kabla waage, nilikuwa nagonjeka lakini napelekwa tu hospitali, sipimwi. Napewa tu hizi madawa za kawaida, narudi kwa nyumba. Na ni kitu ya on and off.
The biggest thing that sickle cell patients have is infections. They are very, very susceptible to infections. And that's why if you looked at how we manage them here, we give them the smaller ones. We give them an antibiotic called penicillin V. Na wanaitumia kila siku, whether they are sick or not, to try and prevent an infection entering their body.
2016 December ndio niligundua kijana wangu ako na ugonjwa. Hasa sikuwa nijua ni ugonjwa gani.
We used to take her to the hospital. Normally, when a baby is sick, the parent would be like, tumpeleke hospitali. So we take her to the hospital and she's given drugs for the headache. 2-3 days, the headache is gone. And then after the 4th day, the headache comes back. Just embracing and accepting that our baby had a tumor, it took us around a week because it was heavy on her.
The disease has been quite expensive and a challenge for me and my family because the surgery that I had done last year cost 1.7 million, and fortunately for me, insurance covered all the costs for the surgery. This year, I came for routine checkups and I found out I had 4 new tumors. So that's when I had to restart chemo this year.
When somebody is diagnosed with cancer, it affects the community because you realize this person is a father, is a mother, is a sister, and in some cases they are the primary breadwinners. So being diagnosed with cancer, going through treatment, looking for funds definitely destabilizes the family unit.
She's taking 33 sessions of radiotherapy. The 33 sessions is costing $500,000.
Treatment of this diabetes is costly. People think it is only drugs, but there are so other requirements beyond drugs.
Nutrition comes number 1 at 65%. Exercise comes second at 26%. Stress management comes at 10%. Treatment at 5%.
What we do so that we may be able to continue and we may be able to survive maybe for that long, we try to go for the cheapest thing that we can be able to afford.
I find it slightly easy, simply because my wife is a contributor to NHIF. Actually, this is what is helping. I am now talking about the majority who are not able to access to NHIF. What is going to happen to them? You are not even going to happen to them. What's really happening to them?
Pesa zote ile napatanga kidogo huwa natumia. Sichitumutu kumkatia NHIF vitu kama hizo.
I don't have a medical insurance because I'm currently not engaged in a job, so I cannot pay for my medical insurance.
There are also services that are not covered by the National Hospital Insurance Fund for diabetic cases, for hypertensive cases.
It's been very hard because sometimes ninapelekwa Kenyatta, unalazwa.
Umekuja, you have pain, and we put you in the ward, and we manage you on the average of 3-4 days. We do a few blood tests, and you require 1 blood transfusion. And then on the average, you stay for about 5 days, and there are these dawas that we give you regularly. You need about 230,000 shillings, 1 admission.
The other big challenge is medication. It's expensive. Our patients come, they see the right doctors, but they can't afford the medicines, most of them.
Sickle cell disease is a neglected disease. But unfortunately, it takes away many of our children. They die as malaria, and it's not malaria. They die as pneumonia, and it's not pneumonia. They get strokes. They also die by depression.
In Africa, the statistics say that between 50 and 80% of children born with sickle cell die before age 5. Why? Because of care. Some even without ever knowing what killed them.
The human resources for health, the nurses and the clinical officers, have practiced in an environment that only dealt with malaria, TB and HIV for a long time. And therefore their knowledge and skills for advocating for healthy behavior for NCDs and screening for NCDs and giving primary care for NCDs has dwindled over time. And therefore they require new skills and education to be able to align themselves to this growing problem.
Stroke has not been even accepted as a medical emergency, which actually we are fighting for.
The second challenge has been availability and supply of essential medicines for primary care of NCDs, especially antihypertensive medications and simple diagnostics, diabetes medications and simple diagnostics, and also cancer screening for cervical cancer, breast cancer, and making sure that they are detected early and referred before they are too late.
2 years or 3 years ago, if you had a heart attack, there'd be no money available to you. Now at least you get 500,000 if you have been keeping up with your NHIF and you have all your documentations. But the main challenge we have is that we are able to make a diagnosis, but we're not able to move forward and provide treatment because of financial issues. Yeah, so you'll have young children who maybe are 5 or 8, 6 years old, who have a heart condition, whose parents are extremely poor, who still have access to the 500,000, say, for a heart surgery, but they still need to get another 500,000.
Many emergencies which occur as a result of preventable lifestyle changes, and that much more effect in control of these diseases will be achieved if we adopted healthy living habits instead of just clipping the leaves of a very big tree.
Watu wa slum sana sana si ujiambia non communicable diseases, something like cancer haziwezi tushika si watu wa slum, kwa sababu cancer inashikaga wale watu wako na doo ama nini.
Mahali kama Kibera penye tunaishi ni watu wachache wenye wanajua vitu kama cancer ni non communicable diseases na vile zinakosiwa.
Sisi kama youth tunapenda hii life ya kupati, life ya kusmoke, vitu kama hizo. So unapata hiyo ina increase more chances za kuget hizo ugonjwa.
There's new technologies that are coming out, but the main thing is prevention. And prevention is just about lifestyle and people knowing what to do before they have the disease.
Cancer is going to be a major burden in Africa and low-income countries. So we need to be prepared for it, and that means we need to finance the local hospitals, and not just financing, but also train the local doctors on cancer management. What are the diagnostic protocols, so that they are aware, and we don't have to bring every patient to Nairobi. So long as the people in the local hospitals are trained, they can be able to manage those cases locally.
So we need to have a place where the county enables the clinical team to have regular quality training, where if I am going to take you for this course, these are some of the things I need you to meet. And by the end of the day, there's an impact evaluation.
If we had policy and systems and structures and protocols, that would guide a lot of things. Because once you have policy, then how do we implement this policy? You know, then everything else will fall in place. Training, drugs, protocols. When someone arrives, what happens? You need blood, you need medication, you need water. That would be very paramount.
There should be centers of excellence that look after sickle cell patients that are provided for in each and every country in the where sickle cell anemia is a problem. But up to today, how we treated sickle cell anemia in the 70s is still how we treat sickle cell anemia in this 2018. And because of that, we must address this issue as an emergency.
Serikali yetu inatakiwa iingilie maneno katikati, isaidie kabisa, ndani kabisa. Kama watoto kama hawa ni shule, sio waende shule zingine common schools. They should be wawekewe shule zingine zile watasomea ili kwa ajili they need care. Wanataka care.
We need to be included or involved in decision making forums, either at the county level and also at the national level, especially when they are planning for the budget of non-communicable diseases.
The community needs to also be a little more educated on how to engage the policy process. Usually these policies are done by hearings that happen before the budget. Majority of our population do not understand how to participate in the policy process, in the budget process. So we need to educate our population also in how to advocate for their rights and also exercise their responsibilities.
I think the government and the county are doing a good job given the immensity of their problem. Of course, I mean, there are many things they could do better, yeah. So making sure that the health facilities have adequate infrastructure, that the lines to get medication are more straightforward and more affordable than they are.
I would like to tell the NHIF and any other medical insurance to consider what a diabetic person goes through. At the end of the day, this person may require extra drugs. This person may require glucometer and the strips in order to measure them. So what they can do is that they can inculcate the system with the drugs. For example, instead of going to buy drugs and then later pay for the NHIF, it doesn't make sense.
Action can only happen if appropriate resources are allocated. Currently, almost 80% of our health budget is usually taken to TB, malaria, reproductive health, which I think is okay. But if you consider that 30% of mortality is due to NCDs, then it's only proper that at least, if not more, 30% of the health budget should be on NCDs.